Good afternoon and welcome to the University of Tasmania's Island of Ideas online public lecture series. Firstly, as a reflection of this institution's recognition of the deep history and culture of the island, the University of Tasmania wishes to acknowledge the traditional owners, the Palawa people, who are the custodians of the land upon which we meet, and we pay our respect to elders past, present and emerging. Hello everyone, my name is James Vickers and I am the Dean of the Tasmanian School of Medicine. Island of Ideas is an online program designed to keep the ideas flowing during this period where we are unable to host live public events. So each year the university presents hundreds of lectures, forums, seminars and workshops for our students, alumni and the wider community. These are very much an important part of the university's role in the silent state of Tasmania, and it's why we're hosting forums such as this one this afternoon. So just a few housekeeping notes before today's lecture gets underway. For this Zoom meeting, your microphone, camera, chat and other functions have all been disabled, so our speakers are not interrupted during the lecture. But we do encourage you to ask questions. We very much welcome your questions, and this can be done by typing them into the questions and answers function that you'll see at the bottom of your screens. And a selection of these will be answered during the question and answer section towards the end of the presentation. And finally, also just to remind you that this lecture is being recorded for later access through the university's social media channels, and indeed we'll be sharing these with many of our health professional students throughout the College of Health and Medicine. Now, this annual lecture honours the memory of Professor Arthur Cobbold, who was an absolutely seminal figure in the establishment of the Tasmanian School of Medicine at the University of Tasmania. As well as medical education, Professor Cobbold also contributed substantially to health policy and administration in Tasmania more broadly. No early alumnus of the Tasmanian School of Medicine really needs an introduction to Arthur Cobbold. From 1964, when he was recruited as Foundation Professor of Physiology, until his retirement 21 years later, he very much shaped the school and the lives of many of those in it. He served as Dean of Medicine for 13 years, which is something of a record for a Dean of Australian Medical School. He was also remarkable because he really maintained a substantial teaching load during his deanship, which was really a mark of his commitment to medical student education. He was an inspirational lecturer, an active researcher, and perhaps above all of that, absolutely an excellent administrator. He was much loved by his students and over 3 decades had immense influence on medical issues in this state, particularly as chair of the board of the Royal Hobart Hospital. He was also very committed about the role of the Tasmanian School of Medicine as having a central purpose in helping to create and shape the medical workforce for the state. And this central purpose remains today. As an important legacy of this, many of the senior clinical leaders throughout the state today are alumni of the Tasmanian Medical Program and were taught by Arthur. So it is a most fitting memorial to the late Professor Cobbold that an annual lecture on contemporary medical issues continues to strongly influence thinking about health in Tasmania. In this regard, I would like to especially welcome members of the Cobbold family to the lecture today, as well as previous colleagues and students of Professor Cobbold. Now, a great pleasure to introduce the Cobbold lecturer, and the Cobbold lecturer today is Professor Dale Fisher, an alumnus of the Tasmanian School of Medicine, graduating with his MBBS in 1985. Professor Dale Fisher is widely credited with Singapore's achievements in containing the coronavirus, and he's become one of the most sought after experts on the disease with media appearances around the globe. I believe this is actually one of 4 presentations he's doing on coronavirus just today, so we're very grateful that he's able to be with us. By way of background, he's the Senior Consultant Infectious Disease Physician in Singapore, and he is also a Professor of Medicine at the Yong School of Medicine at the National University of Singapore. He also chairs the country's Infection Prevention and Control Committee and the WHO-affiliated Global Outbreak Alert and Response Network. In February of this year, Professor Fisher was part of an international technical team that travelled to China to understand this current COVID-19 outbreak. Professor Fisher first worked in Singapore in 2003, arriving at the SARS just as the SARS outbreak was hitting. And he's been part of many missions responsible to various other infectious disease outbreaks across Asia, as well as the West African Ebola response. Professor Fisher has an absolutely excellent research publication track record with over 200 publications. And so now it is with great pleasure that I call upon Professor Fisher to deliver the 2020 Arthur Cobbold Lecture.
Thanks, James. You can hear me okay?
Yep.
Yeah, so thanks, James. Thanks, David, and other members of the team that have helped put this together. It certainly is a prestigious and humbling moment for me giving this oration. And many of my colleagues that I know are listening would agree completely that I should be humbled by this. It's not probably what many would have foreseen back in university days. I do remember Arthur well. That's what we used to call him, and it was with great affection. We didn't speak of all our lecturers and tutors with great affection, but Arthur was certainly one. We would never call him Arthur to his face. Of course, he was Professor Cobbold, but no, it was an affectionate relationship. There was an aura about him. He was kind of scary, but he didn't give you any reason to be scared of him. He was clearly a kind person, had enormous respect. We all knew that he was largely responsible for delivering the School of Medicine. He would give us a talk at the end of the or after dinner speech at the medical student dinners, and I remember he was always very nervous, and he acted quite nervous, and we never really understood that because he was kind of larger than life. So why would he care about a rowdy? Why would he be nervous about talking to a rowdy group of students? But nonetheless, that he was. Just let me share my screen now. So I hope that's clear. I'm going to go through some stories, if you like. It's probably the best way to present the sort of outcomes I'd like to get to. So I'll apologise in advance for what might appear like some self-indulgence, but I thought I should start at the beginning. And this is the first time I came to Tassie as a little boy on the Princess of Tasmania. Here I am at Hutchins, and you can probably start to see it really is a larrikin bunch, I guess you could say. And but I guess I was saved by this scholarship, which actually sent me to Singapore for my last 2 years of high school. So I guess that was one of the first times I took a risk, if you like, in leaving the nest. I came back, did medical school. This is my cohort in 1985, and if you look hard, you'll be able to recognise people like Peter Dargaville here, who'd be well known in paediatrics and neonates, leading the unit for about 10 years up until 2015, and still doing good research now. Mark Bowie was a close colleague, and Hugh Burke, Annette Douglas. I could probably name most of these people still, the inseparable Anne-Louise and Tanya. So a lot of these people I am still good friends with, keep contact with, and it's really a great time those university days. I have to say though that I do have to put a disclaimer that I really wasn't a very good student. I wasn't winning prizes. I was getting through, having the time of my life. We turned cramming into an art form, and not while I'm suggesting this is a good way to do it, but perhaps those medical students that aren't at the top of the class can take some hope in that respect. So after medical school, there was graduation, and this is really to show my family and the amazing fashion sense of the mid-80s, that people actually did their hair like this and had moustaches like this, so and wore ties like this. So this was graduation day, and I think probably the next day we were off to Hamilton Island, and there you can see Dargs again, and Tanya and Annette Leach and Mark Bowie, Annette Douglas there, Peter Mahulik. So that was a great week, but pretty much after that, there'd been an arrangement established with Darwin that a couple of Northern Territory students would come down to the University of Tasmania Medical School, and in return they would take a couple of interns up there. So I was chose to be in that program, and really enjoyed getting into the sort of the Aboriginal health situation, the understanding of I guess underprivileged and poor health in one of the wealthiest countries in the world. So that was sort of my intern year, down to Sydney to do infectious disease training, and then back up to Darwin. So this was some time in Darwin. Also got to meet Jerry Lewis while I was there. I recall being at the races for Darwin Cup, the horse races, and someone came and said, "Look, we've got a patient that needs to be seen." And I looked at him with a long face, and he says, "It's Joseph Lepitz." And I said, "And?" I said, "Well, you know, can you go and see him?" And I sort of went, "Yes." And of course, I later realized that was the real name of Jerry Lewis, and he had viral meningitis at the time. And this was an early message in not taking yourself too seriously, because Jerry Lewis had nothing but praise for Darwin's Dr. Dale Fisher on the Larry King show, saying Dr. Fisher was the world's best infectious disease physician. So there you go. I thought about the reality of that for about 1 second. And nonetheless, he was a very, very wise guy. We got to know each other over about 2 weeks, and a lot of useful life insights, and needless to say, extremely funny. Another event in Darwin was the Bali Bombings, where we had about 1,500 people appear. No, sorry, that was a different one. About 60 odd people appear from this on a Monday, with the bombings happening on a Saturday night. So we had quite a overcoming in Darwin, and we really had to evacuate all these people out. And I recall going to the head of surgery, John Tracy, and saying, "Look, we're a group of physicians. We don't seem to have much to do here with all these burns and trauma victims." And he said, "Yeah, we've got it under control." And he came to me about 15 minutes later and said, "Dale, we've got 2 wards full of incredibly sick people. We're in theatre. We don't know what antibiotics to give. We don't know what electrolytes to give, fluids to give. We don't even have time to examine them." So we stopped everything we were doing, completely adapted, and just started rotating around the surgical wards. And this was really I think a hallmark moment for me personally in outbreak response, because you learnt the importance of adapting and really doing no fuss, not taking anything personally, just getting on with the job. And that was really extraordinary. I recall being up all night organising how to evacuate all these people out, because Darwin didn't have a burns unit, so these people were only going to get worse. So that was the Bali Bombings, but I stayed in Darwin for about 12 or 13 years, and decided I better look for something else. And I look at all my happy colleagues that I'm leaving, and nonetheless, this was Bart Curry. He was a great mentor for me in infectious diseases. And as I arrived there, it was SARS time. This was March 2003. I'd actually called my colleague who was recruiting me, and I said, "Do you still want me to come now? It sounds really chaotic." And he said, "Absolutely." And I got there about the same day as the first case arrived in Singapore. And as you know, they'd come, the amplifying event was in this Metropole Hotel. So it had happened there, and it had really, if you really want to spread something around the world, put it into a group of travelers. And you can see, as well as spreading around Hong Kong, coming from Guangdong, it also spread most famously to Singapore and Toronto, but also there were a smattering of cases elsewhere. But this was how the outbreak of SARS occurred. And it was again how you adapt. There were like twice daily meetings. There were media to manage. There was a hunger for information about what this novel virus is, and we were giving talks, back-to-back talks most of the time, just to feed that hunger. And of course it was fear, because a lot of healthcare workers were getting infected. So that was the SARS outbreak in Singapore. About 220 people, I think, were infected, and about 30 deaths. So for the hype around SARS, because of the viral shedding aspects, it really was a disease focused in hospitals and amplified in hospitals, as opposed to the more community spreading of the current COVID-19 outbreak. So I was getting really interested in outbreaks at the time, and I just wanted to show this graphic, which isn't mine. It's a colleague in Africa, Yoti. And this is at the end of the Uganda outbreak in 2000, 2001. And you can see you've got all the aspects of the outbreak. You've got contact tracing teams here, doctors, data people over here, and you've got this chart here. And if you look at this chart, and I swear by this, and it's still a message that we're not getting now through COVID, that there are pillars of an outbreak response. And you can argue what those pillars are, but case management, laboratory, social mobilization, which is engagement of the community, and surveillance and epidemiology. And within those, there's contact tracing, data management, case finding, all these other sort of secondary levels. And this very, you can see it's actually pinned to a wall in Uganda, has really morphed into what is an iconic picture now, which responders use from Global Outbreak Alert Response Network, and we look at it this way. And this was actually one adapted for the West African Ebola outbreak. And again, you can see these pillars, and it's really what a lot of people are forgetting when they fight COVID and focus on lockdowns and border closures, that this is how you actually confront an outbreak. Is there enough community engagement, psychosocial support? Is the case management being done the right way? Surveillance, epidemiology, laboratory, all the logistic things, and how is it all being coordinated? So this is some scenes from West Africa where there's a lot of training. This is actually up in Lofa. This is in the epicenter of the outbreak, where the three countries, Sierra Leone, Guinea, and Liberia meet. And these were the healthcare workers that there'd been 5 deaths in this hospital, so they hadn't been back to work yet. They were just scared. And here's some talks in other things, but in other health centers. But this was a major concept. A lot of people had conspiracy theories, and they sound familiar, right? But outbreaks do attract conspiracy theories. Is it actually a real thing, or is it political or government or something like that? So by September 2014, it was really things weren't good. The Ebola treatment units were overcrowded. Garbage was accumulating, and it's like everything that you do normally was overwhelmed. Dead bodies couldn't be collected. I knew of people that had their relative in their house for days unpicked up, because they were getting up to like 100 deaths a day, which was way out of it, and you have to deal with them in a safe and dignified way. So this is a very confronting time during an outbreak response, how you actually manage the dead. And we're seeing that in COVID as well now, with mass graves well, they've been in certainly in Brazil and US and Europe, and we're going to see more of these. One of the more rewarding moments was coordinating this group. These were all the NGOs and other organizations in Liberia at the time that I was there, and there's about 40 of them, and they were all doing infection control, and they all had different policies, they all had different trainings, and we had to pull it all together, because we might go somewhere to do something and we find someone was there the day before doing a training, and we'd say, well, what did they train on? What material did they use? So we had to create everything. These were WHO, he was CDC, this is Ministry of Health, she's CDC, MSF were also there. And we pulled together what became the National Infection Prevention and Control Strategy. So, and declared that no one else could teach on anything else. All trainings had to be approved by the ministry, and they had to use our materials. And this lady suggested that we call it "Keep Safe, Keep Serving," and that looked like that. So this logo had to be on everything. And I remember coming back in February, and they asked, someone's doing a training, can you go and just check if they're doing a KSKS training? And I said, what's that? And they said, keep safe, keep serving. So it was a lot of fun seeing that the name had lived on. So anyway, it was, apart from trainings, it was training of trainers, and this was about 120 people that were going to go out with all these materials. This was the WHO country office meeting. This was just inspecting a place with all these children have been orphaned by Ebola. So we were just trying to find somewhere new for them to live. So you do what's ever called on you. Anyway, so I moved on from Ebola as that went away, and I became chair of the Global Outbreak Alert Response Network in 2018. And this is giving our first intervention at the World Health Assembly. And if you want to get nervous about a talk, go there. That's me sitting there. This is really daunting when you get introduced by someone up there, and then all these cameras swing on you. So that's why I'm not looking very happy. So let's talk about COVID. Yes, I was introduced as going on this mission, and this was really I found it a personal highlight, if you like, in my career, being asked to go on this. It was we left February 16. We were only there for 9 days till February 25th. We landed in Beijing. Not all of us went to Wuhan. I didn't go to Wuhan. I thought that might be a bit too tricky to come back to Singapore, having just been in Wuhan. So, but Beijing, Chengdu, Guangzhou. So this is how we could try and get as much information as we could about what was happening. And as I say, this is February, so we're only really 6 weeks into it. And there's a lot of meetings. This is quite a high-level meeting with the administrators in Beijing. You can see these television screens in front of us, and that's where they were really sharing a lot of information. And what I love seeing is how so much of it is still true. They talk about healthcare worker infections, the asymptomatic cases, not so many mild cases, mild pneumonia, but what we know, that only about 20% actually end up with severe and critical disease. They shared on how they did their testing. This is why I chuckle when people insist that we look for the origin of the virus. This was happening back in February. They were swabbing a lot of poultry, pigs, cattle, and just trying to find another source of how it might have jumped from bats to what was the intermediate host. And of course, we're still none the wiser, except we know a lot of cats get it. So this data also came out, and this is what I was alluding to earlier, that you can see that there's actually the viral shedding, whether it's nasal swab, throat swabs, is really pushed towards the left. Whereas in SARS, it was pushed towards the right. So as people got sicker in SARS, in hospitals, they shed more virus. Whereas here, you can actually see, even on day 0, that there's quite a lot of virus being shed. and this is what we now know, that it can spread pre-symptomatically. These are, and the other thing you can see is we know we can't culture it or do whole genome sequencing if the CT value is above 30, and you can see that really after about 2 weeks, there's no CT values above 30. This is why we kind of like around 2 weeks. Some add on another 7 days or something for security, but really it's quite uninfective towards the end. So we went around lots of hospitals. These are just some pictures from the trip. This is Bruce Aylward, who was the leader of the trip, Maria Van Kerkhove, who you will see on the Director General's left during all the press conferences. This one was at China CDC. This is Chengdu Airport, and you could really, not that you needed it, but this was a real shutdown, and we could really get an understanding of how the world had, China had really shut down. This was the airport, just a handful of flights happening now. But Beijing had blue skies. You could walk along the streets for 10 minutes and not even pass anybody. I actually recall thinking, is all this really necessary? But since then, with the rest of the world locking down at one stage or another, we can see where that came from. This was Sichuan again, so meeting with high-level officials in that province. Just again, this is meeting with doctors, visiting their fever facilities. So if people are triaged and they're possible COVID, then they're not into the hospital. They go here for their initial screening, and this is very commonplace. We went out into the communities again just to get a sense of what a shutdown was, and you can see over here the screening of people. Everywhere you turned, you'd have your temperature taken. People really had restricted movements. This was all audio, visual, everywhere about precautions to take. This was the railway station, also in Chengdu. Again, well, it speaks for itself. No trains. This was one of our colleagues. He came through the temperature screening and had 39.2 or something, and he went, "What?" So he went and took a picture of it, and when he went through again, it was okay. This was a pediatric hospital, again, where we learned how they divided things up into green, red, and yellow zones, and really limiting the number of people in all these presentations where we can stop and ask questions. This is Chikwe, head of Nigeria CDC, who was part of our mission. And again, just more pictures. This was speaking to some doctors who were doing a teleconference on some COVID patients. Mixing with epidemiology teams. The reason I'm showing you all these slides is because people say, what did you get? How do you know you could believe what the Chinese told you? To which I'd say, well, it was a really consistent story because it was in several cities, all levels of people. It was doctor colleagues, it was the administration, it was junior epidemiologists, and that they would all tell us things that weren't that made sense and that were consistent. But what we also learned was that they were ramping up when this was really at the peak of their outbreak, but they didn't think it was going to be over. So if we spoke to a lab manager, he would say, yeah, now I can do 5,000 tests a day, but next month I want to be able to do 20,000. So they were afraid of what this virus could do. And we spent the last 2 or 3 days of the mission writing the report, which is fairly well known. It's about 40 pages now, and it came out with quite a few things. The transmission dynamics. Toke spoke about family clusters, household attack rates. The closed settings, nosocomial, prisons, restaurants. These are all things that hadn't been in the rest of the world yet, but it's and interestingly, school outbreaks have not been a feature of this outbreak, but it may be because closure of the schools, because the schools are closed. So here we are in July, and we're still wondering about school outbreaks, and a lot of schools are closed around the world. So So things that were a question mark then are still question marks. This 80% and 20% is are more severe is a thing, and it's consistent. And the exposure to onset of symptoms is 5 or 6 days. All these things that we learned back then have really only been verified, and these are just cut and pasted out of the report. Asymptomatic infection is unknown. This was a big question mark for us, which we're now much more concerned about, and children have milder disease. And this is the bit that I've already mentioned. Viral shedding can continue for 2 weeks, and even when people recover, they can stay PCR positive. So as I say, everything that we learned has been maintained. And this was their epi curve at the time. We'd seen what had been done, and really by introducing the non-pharmacologic interventions, basically otherwise known as a shutdown, to work with all the usual contact tracing and things, they really knocked this off. They flattened it, they crushed it, whatever you want to call it, and since then it's really remained at very low levels. There were quite a few conclusions. I've just pulled these ones out. I remember distinctly this conversation. The rest of the global community is not yet ready in mindset and materially to implement the measures that have been employed in China. And that was one of the personally disappointing things to me, was that we couldn't get the message across. Everyone still had to go through their own lockdown, even Singapore. But proactive surveillance, immediately detect cases, rapid diagnosis, immediate case isolation, tracking and quarantine of close contacts, and a high degree of population understanding and acceptance of these measures. You could write that out word for word now as what's important, and we wrote this in February. The time gained during so it still wasn't out in the rest of the world yet. There were just a handful of cases, and it was China had given the world a lead time to prepare and get their testing and everything in place. But of course that didn't happen. It's like everyone had to learn their own lessons, and that's every country. So where are we now? This is this morning. 15 million cases, clearly an underestimate, and 620,000 deaths, also clearly definitely an underestimate. The outbreak is being largely driven, this orange one is the US, so 30,000 cases a day, came down to 20,000, undid all their lockdowns. Now they're up in the 60 and 70,000 cases a day. Brazil was number 2, sitting around 30,000 cases a day. This is India on its way up, and now South Africa, which is facing real trouble, is the only other country diagnosing more than 10,000 cases a day. This is the world epi curve. So what's interesting to note is the pink here is China. So it's absolutely dwarfed. They've got a total of 85,000 cases altogether. And you can see pink representing the Western Pacific region really is a very small component of this outbreak. What's interesting is yellow, which is the Pan-American, that's all the Americas, so includes Brazil and the US, which was kind of a little bit late to the party, but is certainly the major epicenter. So what's happening? Africa is on the way. Obviously, they have a lot of problems with testing and things and reporting, but that's the current biggest fear. Eastern Mediterranean, Europe is quite interesting. They're running 2 kind of outbreaks now. The Western Pacific Western Europe is improving in terms of numbers, although I'm not sure how long that will last. But Italy, Germany, France, Belgium, all of Scandinavia except Sweden are all now opening up their borders and working together. But as I say, I think I'm not sure they've got enough good things in place. But why this hasn't come down is because Eastern Europe and the Balkan states Romania, North Macedonia, Serbia, Croatia. These countries are all going the wrong direction, so that's why you've sort of come down, but it's now flat. This increase in our region is Philippines and Australia mostly. So you can see here, these are the country epi curves, and you can see what Philippines. So Philippines did have, if you've got mild disease, stay at home. They're changing now to centralized isolation. Unfortunately, they're doing that by police going door to door to try and find people with symptoms. So that's anyway, that's how they're managing it. Singapore is coming down after its dormitory outbreak. Japan, this is a lot of this is happening in Tokyo, in nightclub districts. This is my favorite epicurve. This is the one I call really living with the virus. So they had their big outbreaks in Daegu and other areas, but now they rumble along at about 40 to 60 cases a day across the whole country, identifying cases and stopping clusters. And I don't think I need to tell anyone in the audience about what's happening in Australia, which is obviously mostly Victoria. So in Singapore, this was our dormitory outbreak. This was a huge, this was the day before our outbreak. The day before our lockdown. This is a dormitory of 25,000 men. It's basically a town. Each of these blocks holds 2,500 men, and there's 10 of these blocks. So you can see 3 of them here. And we had to go in and help, and there's that graph again. It was how we could implement all these things, which I won't go through because of time, but it's how do you communicate and get the message through to the men, because they're now all locked in and not mixing with the rest of Singapore's society, because that's sort of isolating an outbreak. But how do you look after their regular health needs? How do you get all the logistics to them? How do you do epidemiology? Because some blocks were more affected than others, and some floors were more affected by others. So we had to do all these types of issues. Here are the Singapore epicurves, and you can see that actually, well, imported cases, there's just a handful of those. They're all in quarantine, obviously. The community cases is the interesting one. We came out of our lockdown about here. So Singapore has now been about 6 weeks, not completely open, but pretty open, but wearing masks, and less than 20 cases every day. This is the dormitory residents, and this is, you can see this is 45,000 of our total of 48,000, and that's quite a long tail because the outbreak is very difficult to put out. There's like 1.2 million foreign workers in the country, so with about 1,200 dormitories. But the strategy here has been in the dormitories to pull out anyone that's over 45, and they get to stay in a 5-star hotel for a little while. And you can see this is why we've had really just 27 deaths out of 48,000 infections. So it's really quite remarkable. And even now we're still diagnosing a couple of hundred people a day, but we don't have anyone in ICU. So let me just talk about a few controversies, and I'll try and close. Masks, we used to just say wear it if you're sick, but with the knowledge of pre-symptomatic spread now, I think it's one of the biggest differences between Asia and the rest of the world is that the community feels more comfortable, or more comfortable than Western countries wearing masks. As I say, it used to be just when you're sick, but now as soon as there's significant transmission, then we just say wear masks whenever you leave your house. It does have some other benefits. I mean, it protects you, it protects people around you. It reinforces messages that, you know, you put that on your face, it's hard to forget that you're in a pandemic. It probably also stops you going out so much because they're quite annoying to wear. Just a little bit on vaccinations, everyone's asking. We've got, there's about 130 in candidates. 24 of those are now in human trials, and 3 or 4 of them are in phase 3 trials. It's very important we don't rush these. I think we're on target. I don't think we're ahead. I don't think we're behind. I think it's very good we've got 130 candidates. That's quite unusual for a vaccine development. But if we rush phase 3 and just do it in a couple of thousand patients, we're not going to recognize rare side effects, for example. We're not going to get a full handle on how long the antibody response is for. The anti-vaccine campaign is very strong. It's never been stronger. There's a good chance we're going to have a vaccine, but there'll be a large percentage of people that won't take it. So we have to prove it to them and prove it to us ourselves that it is a safe and effective vaccine. The whole argument versus eradication versus suppression, I think, comes down to expectation. I don't think sustained eradication is a good plan. I think you want to be like everyone else. Sweden tried to be different, and now all they've done is had a lot of deaths and ended up with the same economic problems because their neighbours are there. I think eradication really means that it's very difficult to open your borders. There'd be a lot of criticism if you had one case, and it's also on the basis that a vaccine is coming and it's coming soon, and there's no guarantees of that. There's no guarantees it'll be here in the next year. There's no guarantees it will have 100% efficacy, and there's certainly no guarantees that 100% of people will take it. So I think at the end of all this, any country or state that does bunker down, I think you're going to have to face clusters anyway. So it's really about having a really strong public health system that can identify cases and trace contacts. So I think lockdown and border closures, I think they've had a great role, but I think we need to work out better how to live with the virus. We published this last week in Lancet as a commentary, and came up with a table of things where you can actually do a self-assessment just to see, you know, if you can identify cases early and stop transmission chains, then it doesn't matter if you're having a couple of cases and you're open borders. And if your neighbour is in a similar way, if you know that people coming from Singapore have, if they were contacts, then they would be in quarantine, then you can feel much more comfortable that that people coming to your country from that country are very unlikely to have disease. And if they do, on the rare chance, then you've got a good capacity to identify that and shut it down. So this is really a number of criteria which we would suggest using. So just in closing, I want to give a little bit of a plug for this webinar series. I was asked in March to do this. We've now been doing, I think tonight is the 15th of a series of 24, so it's certainly tiring. Tonight we've got Richard Horton. Last week we had David Patterson, Peter Piot. We've got Mike Ryan and Maria coming up. We're pulling in on all our networks to get great speakers at this. I hope you're seeing a theme here of, I guess, of just saying yes to stuff. I became a cartoon character as well at the beginning of this, where these are the COVID Chronicles. There's now about 100 of these. These are just really for public messaging, because the engagement of the community is so critical. And I really canvassed a number of friends and family and said, do you think I should become a cartoon character? I've never seen a professor of medicine be a cartoon character, but they said, yeah, it's brilliant. And I've had nothing but good feedback. And I guess this is what I'm saying is to the students out there, feel a bit comfortable to jump off the conveyor belt, maybe take a risk, whether it's doing something that feels a bit odd, or going somewhere that might be feeling a bit odd, or following a pursuit that other people say. When I left Sydney to go to Darwin, people really looked at me like I had two heads. So I guess feel comfortable with doing. I'm not saying make bad decisions. I'm just saying make good decisions, but then be comfortable saying yes. You get to meet a lot of cool people along the way. This is John Howard after the Bali bombings, and of course Tedros I see fairly regularly. And this was lunch with Lee Hsien Loong back in February as well. You see we're nicely socially distanced, and that was when there was a maximum of 10 people could dine together. But I would say while you're going through all this, I think it's really important that you don't take yourself too seriously. You can get in the paper with some flashy headline, but then it's just a slightly different perspective, and suddenly it all looks completely different. So again, not to take yourself too seriously. I've gone well over time, James, but I hope that's okay. I'll pass it back to you.
Thank you, Dale. That was terrific. Some great lessons and insights on how to respond to and manage infectious disease outbreaks. And we certainly had noted down here in Tasmania that you had become a cartoon character, and that was certainly all over social media and Twitter and so forth. But I think really what trumps that is that you've got this new title, the Jerry Lewis World's Best Infectious Disease Physician. So I think you should definitely put that on your letters and in your CVs. That's fantastic. We've got a bit of time for questions. There's a number of questions there already. So I guess really you did touch on this, but would you suggest a particular strategy, I suppose, for Tasmania and Australia with regard to COVID-19? I guess particularly with Tasmania, like Singapore and Ireland, but much more removed from the rest of the world.
I think there's a huge lesson from Victoria, is that the numbers, it's not about the numbers, it's about your preparedness and your response systems. Victoria has an outbreak and it's in 45 nursing homes. It's in a number of meatpacking works. It's in some hospitals, and these are well-known hotspots. But if you just look at your numbers and go, oh look, single digits or zeros or something like that, that doesn't tell anybody that you're ready to confront an outbreak. So I can't say what's happening in Tasmania. I think you've eradicated it, but I don't think a sustained zero is a good strategy, because you might find yourself still sitting there with no tourism happening, and there's a lot of people rely on tourism. It's very difficult for you to go anywhere without 2 weeks quarantine, which really is a deal breaker for a lot of people. And so I would like to think that you just get your cases down really low and have such a good system that you can respond, you can protect the hotspots or the potential hotspots, and you can act on any case, any cluster, because you've got the systems in place and the surge in place. And I'm no doubt you learned a lot from Bernie.
So I guess just again, putting together some of these questions that you've had experience obviously previously with the SARS outbreak, and there are lots of lessons learned from that. I mean, I guess why was it that it seems the world was unprepared for this kind of pandemic? Where were the issues, I suppose, or the problems, or the wrong decisions potentially made?
They were certain. Why? I think anyone can speculate on that. We certainly felt in China that the world wouldn't be ready. They wouldn't actually think it could happen to them. I can tell you in Singapore, it was first on ProMed, I think, on December 31. I went to ED on January 1 and met them and said, keep a lookout from anyone coming from Wuhan. Well, at first I asked some people what Wuhan was, and then went to ED. We had our first hospital level meeting about January the 5th. There was a cross-ministerial task force at a national level by the second week of January. And we were ready we had tests in 10 different hospitals before we had our first case. So we certainly didn't take it lightly, and neither did Hong Kong and Vietnam and I guess Asian countries that I guess had seen what had happened in China, and thought if it can bring a country of 1.4 billion people to its knees, what's it going to do to us? But
okay, and another question which relates to, I guess, contact tracing apps and their use. I believe there's this one in Singapore. Do you have a view on their usefulness, applicability?
I think they're a potentially useful adjunct. I think the safe entry things are better, where if you're going into somewhere, you scan a QR code, and then you check in and check out. That's in anything in Singapore. I've seen it in parks, but there's no one manning them. But there's usually someone at the entrance of every shop, every restaurant, making you do the safe entry. But the apps, no. Contact tracing, at the end of the day, you still need people that can explain to the case, the index case, I need to know where you've been and who you've been with. Now, automatically you're thinking, am I really going to dob in my friends who are now going to have to spend 2 weeks in quarantine because I told them I'd had lunch with them? That takes a skill. And contact tracers need to be trained and not scary. And then the whole thing of phoning someone or knocking on someone's door and slamming them with a 2-week quarantine order, which is if breached, is a criminal demeanor. Then yeah, it takes a skill. So it still takes a lot of people. If the app can help find a few others, that's fine. Korea does it in different ways. Hong Kong does it in different ways. You can also do credit card chasing, CCTV. There's lots of ways to try and find who was there.
Okay, good. I guess there's a kind of broad sort of issue, but it does I think resonate internationally. And obviously, somewhere like Singapore, there is a lot of potentially, I think, a lot of respect for the hierarchy, the government, the way, how the island is run, on top of respect for science and medicine. Do you think we're seeing the disjuncture of this kind of respect for what the scientists and experts are saying in some countries might now be playing out in terms of their risk for an out of control outbreak?
So community engagement and communication is a strategy that you need to take very seriously. It has to be honest and transparent, and they have to be good decisions. And once you start to lose that, I guess, feeling with the community, you can start to get yourself into trouble. So you can see why, for instance, in Victoria, you could say the communications are going well, but you could also say, listen, these people have already been locked down. They were told they could unlock. Now they're locking down again, and it's really spread like wildfire into places you should have been protecting, nursing homes. So you can start to lose faith. So Australia does it better than many, but I have to say I think Asia is probably doing it the best. But the Middle East, the US are having a terrible time with trust and consistent messaging.
I guess related to that, then, if you might be able to make a comment about international collaboration in this area. And obviously everybody looks at WHO for that particular role. That's had some problems in some countries, I guess. But I guess from the epidemiological kind of response and the vaccine response, they seem to be quite different. So the vaccine response seems to be mostly about companies racing to develop a vaccine that'd be highly lucrative. But do you think there's good international collaboration on the sort of the more epidemiological approach to COVID?
So, what do you mean the epidemiologic approach?
Well, the working with the population, population control and management detection, all of that. Is there ongoing? Is there really very strong international collaboration in that area?
Well, yes, there's a lot of guidance out there, and this is put out by WHO. But WHO, some people think that it can actually walk into countries and act. They can't do anything. They have to act on information that's given to them. They can't go and double check. They can't say you need to do more testing. You're asleep at the wheel. You have to communicate better. There's no capacity at all to do that. It's a political organisation that has to try and juggle all these relationships, and I think is really, really harshly criticised. In fact, we say if there wasn't a WHO, you'd have to invent one so that you could criticise it.
Yeah. Now, I'm just mindful of the time. We are starting to run out of time a bit. So thank you to everybody who put up all of those questions. And again, I'm sorry that we didn't get to all of them. But it's now my pleasure to invite Dr. Rob Walters from the Cobbold Lecture Committee to deliver a vote of thanks to Professor Fisher. Thanks, Rob.
Dale, look, on behalf of all attendees, and specifically Arthur's wife, Elizabeth, and her family, thank you very much for a fascinating Arthur Cobbold lecture this year. Elizabeth's unwell at the moment, but was delighted when you agreed to do this year's lecture. It fits beautifully with Elizabeth's original concept of an annual lecture to celebrate the life of our dear and beloved Dean. Every year from an alumnus about a contemporary health related subject, and I don't think we could have a better example really than the current COVID situation of where that relates to exactly that subject. What a fascinating career you've had. I enjoyed particularly of hearing about your experiences of SARS and Ebola, learning from medical history, which is so vital, and your experiences with COVID-19 and WHO, and of course your current experiences in Singapore, which are so relative to what's happening here in our country. And we look around the world and see places such as Singapore that are a little bit ahead of us, and learn the lessons. We've got a long way to go with this pandemic, and it's vital that the lessons learned and research be shared. And I know that right from the very beginning, you have been at the forefront of that sharing. And as you said when we came on earlier, you've become a Zoom expert, having done what, this is your 5th for the day, and it's only just started. So in conclusion, thank you very much. I can't help but think, what would Arthur have made of all this, with his dry wit, but his very wise and practical mind, which those of us that knew and loved him, were very mindful of. It's often said that a large number of Tasmanian medical graduates punch above their weight for such a small medical school. Clearly, you are a fine example of this and have done UTAS proud. Thank you very much, Dale.
Thank you, Rob. And yes, that's a fantastic note with the School of Medicine. I think what you've been able to achieve and how you're leading internationally in this area is going to be a great inspiration for our current medical students, see what they can think about achieving themselves into the future. So thanks, Dale.